I'm Mandy Novack. I'm an infectious disease doctor, and I'm going to talk about COVID. I don't know if y'all have heard about this virus that's going around right now, but so these are my objectives. I don't remember if I meet any of them. So this is my favorite cartoon of the COVID virus. You hear people even in just like regular news talking about the spike protein, and in the lab we'll sometimes refer to it as the S protein. So S stands for spike. These other letters are other parts of the virus that we test for on PCR. So the PCR is looking at the RNA, the genetic material of the virus, and so different targets, different PCR targets are looking at different parts of the virus's genome. So, but certainly the most clinically relevant part is the spike protein. So the spike protein is what binds with the cell. So this here is a cartoon of a lung cell. And you can see that it binds with the cell and it dumps all of its viral RNA into the cell. So that's pretty typical of most viruses. What's unique to this SARS-CoV-2 is that one of the receptors that it binds to on the cell surface is the ACE2 receptor protein. And so we have ACE2 all over. We think of it as something common in the lungs, but actually there's ACE2 receptors all over the body. And we sort of see COVID manifesting in these different parts of the body. While obviously it's mostly a respiratory illness, we noticed early on that these patients often had kidney dysfunction out of proportion to the rest of their multi-organ system dysfunction. And then we also see these vascular issues, GI issues. Some patients, their whole presentation for COVID is just GI symptoms. And so we think some of that has to do with the distribution of the ACE2 receptors in the body. So this is an old graph, and this is probably a little bit condensed now that we're dealing with Delta. All of these things seem to happen a little bit more quickly with the Delta variant, but the premise is the same, which is that you have this incubation period that lasts a few days, and then you have this replication that reaches some critical threshold where disease starts. And you can see for people that have mild to moderate illness, that whole course is over by about day 10. But there's something that happens in people that are going to have a more severe disease that, and we see this all the time clinically, that at day 8 to day 10, and again, now maybe a little bit shorter with the Delta variant, that people who were kind of trucking along suddenly crash. And you can see here when that happens, when the severe illness is increasing, the viral genome is actually usually coming down at that point. And oftentimes, they'll still be PCR positive for whatever reason. People continue to shed this RNA for a long time, but the actual viral load or replication at that point is relatively low. What's happening then is this storm, this cytokine response, where really the body's inflammation process is what's causing most of the damage. And so I'm not an immunologist. Some of these parts are above my pay grade, but this is a lot of our therapies toward treating COVID disease, especially severe COVID, are actually targeting this process rather than trying to kill the virus. And we'll still do remdesivir, which is an antiviral, and the goal of the remdesivir is to stop viral replication. I personally don't think remdesivir is all that effective, in part because by the time someone's critically ill, it's not because the virus is replicating at that point, it's because of these processes. And so this is what we are targeting when we do dexamethasone and tocilizumab or baricitinib. These are monoclonal antibodies not targeting the virus itself, but targeting IL-6 receptors or other parts of the immune system. So these are some of the speculated mechanisms by which SARS-CoV-2 damages the heart. And I know Dr. Card talked some about the heart and COVID earlier today, so I won't spend a whole lot of time on this, but this part where it actually damages the cardiac tissue itself is probably pretty minimal with COVID. And I wanted to point out that, because one of the concerns with the vaccines is that they can cause myocarditis in young, especially young, healthy men. And so there's a lot of hesitancy specifically focused on that. And so I wanted to draw to light, this is one of the early studies that came out of England. There they call it PIMS. Here we call it MIS, this multi-inflammatory syndrome of children, where it's almost a Kawasaki's-like presentation where these children get critically ill, very hemodynamically unstable, and can have coronary artery dysfunction just like you would see with Kawasaki's. And so this is a single children's hospital in England where they had 15 children in 1 month that all kind of met this category. And so I just think it's worth pointing out that even though in general pediatrics have not been affected the same way as the elderly population with this virus, for one thing we know that with Delta variant, it is hitting younger people more. And even these old variants that were less likely to affect children actually still, relatively speaking, could cause heart damage to kids a lot more at higher rates than what we're seeing with the vaccine. So this is just sort of looking at when they've actually, and there's not a whole lot of science behind this, but anytime they've been able to get tissue of the myocardium in these patients that clinically sort of seem to have a myocarditis with COVID, they're not seeing what we would normally see with a viral myocarditis, where you have T-cell infiltration of the myocytes. What they see instead is this on the left, where there's some inflammatory process with macrophages, but not kind of the typical viral myocarditis that we're used to looking at. And so this is an example of what these patients look like here in the middle is COVID-19, as opposed to here on the right where you would have a viral myocarditis with a lot of T-cell infiltration of the myocytes. So there's, I could talk all day about the many ways that COVID harms the body, but you all know about most of that. So I'm going to talk a little bit more about the prevention of COVID. We often credit Edward Jenner with inventing vaccines. He was the first one that figured out you could use cowpox to protect someone against smallpox, and that's really what differentiated it from what they'd been doing. Actually, this is even perhaps before the Common Era in China. They picked up on this notion that once you've had a certain infection, then you were protected against that infection. And so even 2,000 years ago, there's some Chinese art indicating that they understood this process where you could take a little bit of a smallpox, dry it out, and then give it to somebody in their skin and protect them from a more severe case. The problem with that is they get a little bit of smallpox, and that can be deadly at times. So we're thankful for our modern vaccines, where we can give an inactivated form of the virus or now just a part of the virus that our body recognizes and creates an immune response against. So this refers to the whole family of coronaviruses. And so there's several coronaviruses that cause a common cold. There's 4 main types that have been known about for a long time. And then in 2003, this is like the typical picture that I remember from 2003 when SARS first hit China. So at that time, they did not know it was a coronavirus for many months. Technology has really come a long way since then, but at that point they knew that there was this severe acute respiratory syndrome that they just called SARS for months until they were able to figure out the virus that caused it. And I was in med school at the time. I sort of had this idea that like SARS was much ado about nothing. And it turns out it was actually terrifyingly close to what we're seeing now, that it was actually just barely averted. And in some ways it was it had a much higher mortality, a case fatality rate. So more people that got SARS, the original SARS, died. But fortunately it was caught pretty early, and it was caught in a very authoritarian part of China, and so they were able to get it under control. But what scientists realized at that time is this is inevitably going to happen again. And so they started studying the SARS virus, and then MERS, the Mediterranean virus that caused a similar severe respiratory syndrome, has also been studied. And through lots of different studies and sciences for the last 15 years, they really discovered that this spike protein was what was worth targeting, that it was what caused the virulence, it was what was going to bind to the cell, and so any vaccines that were targeting this virus should target that S protein. So mRNA vaccines have actually been around since the 1990s, hypothetically. And this is just showing lots of different ways. The problem with mRNA is it's incredibly fragile, and so it's hard to put into a cell. But there's all these different ways that for the last 30 years they've been working on trying to get those ready to go, where you could drop the mRNA straight into a cell. The human cell creates this S protein and then creates the antibody response against that. So this is the MMWR study that looks at myocarditis from the mRNA vaccines. That is probably, there's at least an association there. Whether or not it's causative is a little bit hard to say. So you can see here there's a line on the week during the pandemic when they compared the risk to an individual, not at the society level, but to an individual of death from COVID versus death from myocarditis from the vaccine. And even at these very low levels of virus in the community, it was still advantageous to get the vaccine rather than to risk getting COVID. And so they do some fancy numbers there. Go back, where they actually took it down to the individual level, your risk of getting COVID versus your risk of getting myocarditis, and found just like hands down the vaccine is worth it, even when you account for that risk. So those are mRNA vaccines. The adenovirus vaccines are like the AstraZeneca that they use in Europe and the Johnson & Johnson that we use here. Similar, newer concept. We're not giving the actual virus to the patient. We're putting a bit of the COVID RNA into an adenovirus. The adenovirus then infects the human cell, sneaks that genetic material in there, and then the cell creates the response. It releases the antigen, and then our bodies make antibodies against that and T cells that remember that. Johnson & Johnson has been associated with some rare blood clot disorders, very similar to a HIT-like picture. But again, when you look at the risk of COVID versus the risk of the vaccine, the risk of COVID is much, much worse, and the vaccine is usually worth it. So this is showing that inflammatory response. And we are seeing a fair number of people come in with COVID even after vaccines at this point, especially with the Delta variant. But this is an example of how even the vaccinated tend to do so much better than those before by having that antibody response ready to go. So there's my info.